the recording. Okay, so now we started the recording. This is the station 5 case, and Dr. Shaza is gonna take the case. Okay, Dr. Shaza, can you hear me? Before I start the timer? Okay.
Yes.
Okay, so this is your case. Let me share with you. Okay, you have a 2 minute, or let's say 3 minutes. Then we are gonna start. If this PDF is clear for you. Can you read what's written in the screen?
Yeah.
Okay.
Yeah, I can read.
Okay. You have 2 minutes then. Okay, Dr. Shaza, let's start.
Okay. Good evening.
Good evening.
My name is Dr. Shaza. I'm one of the doctors here. Are you Mr. Smith, 39-year-old?
Yes.
Nice to meet you.
Likewise, doctor.
Thank you. We are here to discuss about your health condition, if that's okay with you.
Yeah, it's fine, doctor.
I understand you have got a high blood pressure. Can you tell me more about that?
Well, doctor, I just went to my GP, and honestly, I wasn't complaining from anything. It was just a general checkup. And he discovered that my blood pressure is high. And I'm not quite sure what's wrong or what happened. And I don't have any symptom that I think it could be related to the high blood pressure, doctor.
So you say you're otherwise healthy apart from this high blood pressure, which was recently found?
Yes, doctor.
Okay. So when was the first time it was detected?
Well, I think it was about 2 weeks ago.
And how many times you have checked the blood pressure?
I think I checked it at my home because my wife also had a high blood pressure. I used my sphygmomanometer machine at the home. It was high. It was high. Then I went to my GP. He measured it twice, and yeah, he told me that you have a high blood pressure.
Okay. So I'm going to ask some question. Have you got any other symptoms such as shortness of breath?
No, doctor.
Or heart racing?
No, doctor.
Or a tremor?
No, doctor.
Any change in your weight recently?
No, doctor.
Okay. Have you got any past other medical history which I should be aware of?
Yes, doctor. I have this condition which is called irritable bowel syndrome. I have this diarrhea that keep coming and going over, I think, several years now. But sometimes it's went by himself. Sometimes I took just a medication, lobramide. But aside from that, I'm completely fine.
Okay, tell me more about the diarrhea and how it has been diagnosed. You said for how many time, how long you have this diarrhea?
I think it was, I think 4 years or 5 years back, doctor. But
Okay,
right now, I don't have any diarrhea, doctor.
it's
And
okay
I'm not
now.
taking anything. Yeah.
Okay, and along with diarrhea, have you got any tummy pain?
No, doctor.
Any change in the color of the stool?
No, doctor.
Okay, and you said you have no change in your weight. Any medication you take?
No, doctor. Aside from lopramide from time to time, I'm not taking anything.
Okay, any recent travel history?
No, doctor.
Okay, I'm sorry to ask in this question. Have you ever used any illicit drug?
No, doctor.
Okay. Any family history of note?
No, doctor.
Okay. Any history of kidney disease in the family or heart disease?
No, doctor.
Or any history of thyroid disease?
No, doctor.
May I ask what do you do for a living?
I'm an electrician, doctor. Construction electrician.
Okay. Okay. So let's just ask some other question. Have you got
Eh,
any
Yes, yes, doctor.
Have you got any symptoms such as headache,
No, doctor.
vision problem,
No, doctor.
weakness in your hands or legs?
Well, sometimes, doctor, I don't know if that's related to my high blood pressure. I don't feel weakness per se, but sometimes I feel like I don't know. I notice the color of my hand sometimes it change, especially when I work in the cold weather.
Okay. So does it turn into blue or then its color change to pale and white?
Yes, I noticed some discoloration, doctor. It lasts about half an hour, sometime up to an hour, and I feel like there's some tightness on my hand. I can't say
Oh,
it's a pain, but it's unpleasant feeling, doctor.
okay, very good. Can I examine you? And I'm taking history meanwhile.
Yes, doctor, you can examine me.
Can
What
I
do you
have a
want to
look at
see?
your hands?
Okay, you can.
Okay. I can see there are some rash in the fingers as well. And I can see the skin is very tight and shiny. I'm going to pinch the skin and
Okay,
it's tight. I'm going to check that how far is it tight? Is it going to be up to elbow or is it on the chest as well?
okay. 2 minutes remain. Yeah, it is up to the elbow, doctor.
Up to the elbow and the chest is not affected.
No.
And the face, can I have a look at the face?
Okay, normal face.
Normal face, no telangiectasia. Any problem with swallowing?
No, doctor.
Okay. You said you have no shortness of breath. There is any rash in the face
No, doctor.
or frothy urine?
No, doctor.
Okay. Do you smoke?
Yes, I smoke, doctor.
How many for how long?
Well, I have been a smoker since I was a teenage doctor, maybe 18 or 19 years, when 19
Okay.
years old. Yeah, I smoke like five, sometimes 10 cigarettes per day.
Okay. I advise you to stop smoking and we can help you if you need.
Okay, thank you.
So what's your concern?
What do I have, doctor? What's wrong with my blood pressure?
Okay. So from what you have said, I think you have a problem with your defense system, which is called scleroderma. But it might be related, your high blood pressure also might be related to this disease. It's a kind of autoimmune disease that attacks different parts of your body, including your skin, your nail, some organ in your body, for example, your kidney. So we're going to do some blood tests on you. And we will gonna take after the blood test, we will check the result and we will take it from there if that's okay with you.
Okay.
Do you drink as well?
Yes, I drink.
And
Doctor.
how many units?
I think I drink reasonably, doctor, like 5 units or 6 units per week, doctor.
Okay. So the most important
Sorry, doc
thing is
sorry, doctor. What about this hand discoloration? Is it something serious I should be worried of, or is something no need
yes.
to worry about it?
Yes, I advise you to for stop smoking is very serious for your condition, and also you should keep your hands always warm, and your job also may be a contributing factor to this disease as may aggravate your symptoms. So I will refer you to occupational health department as well
Okay,
because
thank
the
you, doctor. Thank you, doctor.
type of work.
Your time is finished. Now, examiner question. What's your finding in this case? Physical finding, please.
In the physical finding, I find a tightened skin, and it was up to the elbow, and the chest was not involved. And there was no other, I could not find any other symptoms. I did not examine the chest, but the patient has no complaint of shortness of breath, though I would like to examine the chest as well. I would like to do a urine dipstick for this patient to further investigate it, do a analysis of the
Okay,
blood count.
what could be the reason of the high blood pressure in this patient? What's your diagnosis and what's your differential?
Blood test to make sure that is this a diffuse systemic or not. So it might be a part of diffuse systemic sclerosis, is high blood pressure.
Okay, what's your differential?
The differential diagnosis, it could be metabolic cause are possible, but this patient.
Sorry, doctor. I think I was disconnected. Then I reconnected. I was reconnected again. Hello.
Hello.
Yeah. Can you just tell me what's your differential again?
It could be a connective tissue disorder. Most I'm thinking about systemic sclerosis, but I would like to examine for all other kind of connective tissue disorder which might be contribute to this patient, or the patient might have even affecting of the both the kidney as a part of glomerulonephritis.
Okay,
and
how you are going to manage this patient?
To investigate this patient?
Yes.
Okay, I would like to do a complete blood count and the urine electrolyte, and also check the kidney function test, liver function test, do an ANA, anti-double strand DNA, anti-SCL70 to check for the other connective tissue disease as well. Check the urine for dysmorphic RBC.
Okay, how you are going to treat this patient?
Do an ultrasound.
How you are going to treat this patient?
If the diagnosis of this patient is scleroderma, I would like to start with education and counseling of the patient. And for medication, I would like to start an ACE inhibitor for this patient. For the hands problem, also I would like to educate her about warming the hands and using warming gloves and avoiding cold weather. And also we can start medications for that. For example, nifedipine would help with that as well.
Okay, thank you. Thank you. Your time is finished. So let's start the discussion. Well done, Dr. Shazan. I just want to ask you, what do you think the diagnosis in this gentleman?
Well, I haven't gone through the examination thoroughly, but it must be connective tissue disease. I didn't ask about CREST syndrome, for example, if he had any.
Could it be just a simple diffuse scleroderma?
If it is simple, it would not be associated with high blood pressure, to be honest. So
why?
Having the high blood.
Why?
Sorry?
Why it could not be associated with high blood pressure?
Because the CREST syndrome is usually limited. I don't think it will want to involve the kidney.
It is not. Why you are saying it's a CREST syndrome? Why it is not systemic sclerosis, diffuse systemic sclerosis?
No, exactly. I'm saying it can't be CREST because CREST is usually not affecting the kidney. That's why I'm thinking a more diffuse form, systemic form.
Okay, so let's agree. Your diagnosis is a diffuse systemic sclerosis, all right? Or you are thinking it could be a CREST syndrome with essential hypertension, for example, two diagnosing instead of one diagnosis. What are you thinking?
It is usually in medicine, we are trying to collect everything with each other, but that could be a possibility.
Okay, your main diagnose or main differential diagnose, the number one in your list is could be a diffuse systemic sclerosis. Okay,
Yeah.
why the patient with diffuse systemic sclerosis develop hypertension?
It's due to arterial involvement in the kidney.
Okay,
So the way
yes,
to
because of the
hypertension.
kidney involvement. Kidney involvement. Okay. You are almost there. Yeah, because of kidney involvement. We're gonna talk about that just in a few minutes by details. Okay, so let's say this patient has a diffuse systemic sclerosis in addition to hypertension, which was complicated by hypertension. So what's your how you are going to investigate this patient? You already mentioned the investigation, I think, all of them. But let's go back. Let's go back again to the history. What in the history? How you confirm that? What are the screening questions for systemic sclerosis? If you think this patient has systemic sclerosis, what are the
Yeah.
screening questions?
Systemic sclerosis, we should think about involvement of the lungs, shortness of breath if the patient has got involvement of the kidney is very important. The patient has a skin manifestation of sclerosis, such as digital ulcers or gangrene of the ulcers, such like any, even in the limited form and systemic form, the skin manifestation are the same, but the extensiveness of the skin involvement.
Two other organ also are important and can be involved in the patient with systemic sclerosis.
Esophageal involvement you usually can see with patients.
Did you ask about dysphagia?
Yeah, dysphagia.
Did you ask about it?
Yeah.
Okay. What else? What other organ could be involved?
It can be mixed with other connective tissue disorders.
No. I'm talking about systemic sclerosis. Ignore the mixed connective tissue disease.
Okay. So we have pulmonary hypertension, but most Rett syndrome, ILD, most for systemic sclerosis. I'm not sure if it's going to involve the heart or not.
Let me make the question easier for you. This gentleman complained from other symptoms. What he also told you? He told you that I have been diagnosed with irritable bowel syndrome and I have a diarrhea from time to time. What it could be? Can systemic sclerosis explain the diarrhea?
Yeah, systemic sclerosis, because of the movement of the bowel would be involved. It could be bacterial overgrowth for the patient.
Yes, you are right. Okay, so yeah, this is in the history. In the history, you have to screen all the organs that you think the systemic sclerosis may affect. We start with the skin. Okay, I'm going to talk about that by details later on. Let's go into then to the examination. What do you want to examine? You didn't examine the chest of this patient and you didn't examine the heart.
Yeah, I didn't have enough time yesterday because I didn't catch diagnosis very soon.
Okay. But your main area of examination will be the hand, right?
Yes.
That will be your focus part of the body where you want to examine. Okay. In the hand, what do you want to see?
I would like to check for the shiny and tight skin. First of all, look at the fingertips for any peeking ulcer. If there is any gangrene in the hand as well. Look at the nail bed. And I know that the capillary of there's an abnormality in the capillary of the.
But we can't examine that with our naked eye.
It's not in the hand.
We have to bring the nail fold microscopy. Okay, what else?
And the joint may be involved as well.
Okay, what else? Okay, aside from the hand, what do you want to examine else? Let's go. Calcinosis.
Calcinosis is part of a CREST syndrome.
Yes.
So we can look for that in the fingers, in the elbow as well. Yes.
Yes. What else after the hand?
After the hand, we go to the face of the check for the blood pressure, offer that, and check for the tightness of the skin in chest and in neck. Also look at the eye, look at the nose and the mouth.
What do you want before you go to the nose? What do you want to see in the eyes?
In the eyes, it may be like any if the patient has got hypertension, fundoscopy can be offered.
Okay, fundoscopy, but it is not applicable in this case. Why?
Um,
I'm going to explain it later on. Okay, what else? Something more easier, and I think we do it as routine for all the patients. What we
pallor.
looking at? Yeah, pallor.
If
Why do we want to check for the pallor in the patient with systemic sclerosis?
the patient may have got GI bleeding or
GI
complications
bleeding.
like that.
Do you know what is the name of that condition that associates with systemic sclerosis and causes GI bleeding?
Would it cause telangiectasia in the vascular dysplasia in the
Okay, what we
gastro
call it? What we call it? There is a very
angiodysplasia?
simple name, and there is a difficult name. Okay, it's fine. I'm going to mention them. I'm going to mention them later on by details. But what else? What could be the cause of the anemia aside from the bleeding?
The chronic disease
Okay.
would
What
be
else?
with hypertension. They can have hemolytic anemia, although it's usually
Yeah, but unlikely
hematuria.
in this patient because he doesn't have feature of accelerated hypertension
Yeah,
or malignant
and the
hypertension.
patient may get
Something more. It's the most common cause of the anemia in the patient with systemic sclerosis.
the patient may take a non-steroidal for the
For the
pain.
pain, okay.
Yeah, may cause GI bleeding for that.
Okay, what else? Something more.
And any chronic disease can affect the bone marrow.
Bacterial overgrowth itself, it can cause anemia.
Yeah, folate, bacterial overgrowth, with,
Okay.
I think B12 would be decreased and folate would be high, I think.
Mainly the iron deficiency anemia. Usually the bacteria utilize the iron more than speaking about the folate and the vitamin B12. Iron deficiency anemia mainly. Okay, let's go. What else you want to examine? The
Well,
chest.
the face of the patient, pucker
Okay.
mouth and very big nose, and the patient cannot open the mouth. If the patient has got tight skin, they cannot open their mouth wide.
Okay.
Then we could go for the listening to the lung for any interstitial crepitation at the base of the lung. But if it is expressed syndrome, we can go for pulmonary hypertension, loud P2, raised JVP, checking for the pedal edema, ankle edema. That will be the complication of hypertension. Then we can go for the abdomen. For abdomen, I think bruit is not a thing that we want to listen in this patient.
Okay, there is only one finding you can detect it in the patient with systemic sclerosis in the abdomen if they have something we call it pseudo obstruction, or sometimes with the bacterial overgrowth they can have a bloating and they can have a distension. But it's unlikely if the patient did not complain from abdominal pain and vomiting in addition to nausea. It's unlikely that the patient will have a distension. But this is the only finding that you can detect it on the abdomen. Okay, how we can explain systemic sclerosis to the patient?
This is it's an autoimmune condition, means the defense system is attacking and forming scar tissue in different part of your body. For example, in your skin, in your lung, and in your kidney.
Okay, how you will explain his main concern is the high blood pressure. You give him a new information, but how you gonna link it to his high blood pressure? How do you explain for him that his condition caused the high blood pressure? You have to be more specific. So what you're gonna tell? What you're gonna tell
may
him?
affect different part of your body, and one of them is your kidney, and the blood channel to your kidney that may lead to the high blood pressure.
Okay, yeah, this is the proper way to explain it for the patient. I know that you are able to, you will be able to explain systemic sclerosis at the exam, but always focus on the patient main symptoms and try to link his symptom to the definition of the disease. Try to focus on the organ that is affected and led to the current symptoms. Okay, so you are right. Okay, then how you are, if the patient told you I'm working as an electrician, and you told him already that his job may be contributing factor to the symptom that he has. If he told you should I quit my job, what we will tell him?
Actually, I just mixed it up with drilling. I'm not sure if electrician has to quit the job.
It has. Okay, okay. If he told you, should I quit my job?
The Raynaud phenomenon with electrician, I'm not sure about that.
They are using a lot of vibrating tools in their usual duties. So let's say he told you that, or let's say you know that the electrician, they can develop the Raynaud symptoms or Raynaud phenomena or Raynaud disease, and he told you that should I quit my job? What you will tell him?
Then I should say that unfortunately there is a possibility that your job is affecting your hands. So we are referring to your occupational health service to help you with that regard. And I think that if you change, you should change your job if you want to make the change in your nail and problem in your nail doesn't get worse.
Well, okay. I'm not going to say this is the perfect answer, but let's say, will the patient quit his job before he tried the medication, right? Before he tried modifying his lifestyle, before he jumped to the second line of management? Then after that, we can tell the patient, yes, you can quit. You have to quit your job. But I don't think you will ask the patient to quit his job just directly because he has a Raynaud from the first day of the diagnosis. It is not a serious condition. It is not something condition that, it's not a condition that life fatal condition, like for example, patient with Hockham who may develop ventricular arrhythmia and die because they are doing some form of vigorous exercises or vigorous kind of job or vigorous kind of duties. Raynaud phenomena, you are not going to tell the patient directly to quit your job. You're going to try with him the initial medication. You're going to ask him to modify his lifestyle, stop the smoking, wear the gloves, try not to work in the cold weather, and try to stop using those vibrating stools during your work. I'm going to refer you also to the occupational therapist. He may try also to help you. We may try with him the second line of management, the third line of management. If all that fails, then you can tell the patient you have to stop working. Okay, so you have to take it case by case, condition by condition. It is not always wise to tell the patient to quit his job. Okay? Okay. So let's go to the treatment. What is the treatment for systemic sclerosis?
First of all, it's education and counseling about the things that we have discussed over here. Stop smoking, avoid contact with cold weather. If the patient should always put on warm gloves to avoid the cold weather. Then we will go to, after the investigation, we will go for medication. I'm aware that nifedipine, a calcium blocker, can help for the pain in the hand and actually the Raynaud phenomenon. But for the high blood pressure, we have to go for ACE inhibitor.
Okay. If the patient did not respond to the initial calcium channel blocker, anything else we can be used? Do you know about that?
Yeah. Prostacyclin, there are medications such as we usually use them as in advanced form. If you were going to prostaglandin infusion, or we are going to give him the sildenafil, these are, I think, more for serious complications such as pulmonary hypertension will be used. Or the gangrene of the ulcer of the nail, if the changes in nail is severe, that is endangering the life of the organ, I think we should go further for the medications which are actually vasodilator, such as busantan, sildenafil, prostaglandin.
Yes, you are right, Dr. Sheza. And the most important thing in the PACES, you have to know the basic things. You have to tell the patient the basic things. If you mention for the patient that he has to stop the smoking, he has to wear the gloves, he has to be referred to the occupational therapist, we are going to prescribe for him the calcium channel blocker, I think you will get the full mark. If you are able to mention the sildenafil, the phosphodiesterase inhibitor, those are extra mark if the examiner will want to give you something on that. But always in the PACES, what people miss, they don't mention the basic things. We have to focus on the basic things at the exam. Tell the patient the basic and the initial non-pharmacological treatment. Then you can speak about the advanced line of management. Okay. So even for your preparation of the exam, no need to worry about those fancy new treatment, the advanced line of management, because even in the real practice, you are not the one who's going to prescribe those medication to the patient. Okay, most probably it will be someone like the rheumatologist or other specialty doctor who will be the one that prescribes this medication. Okay, so you did well in this part, in the management part. Let's talk about the differential. What could be your differential for this patient?
Differential, first for this patient, we will go for sclerodermic renal crisis. But as a part
crisis?
of no, renal involvement, sorry.
Yeah.
This is renal involvement.
Yeah.
Yes, not renal crisis.
Okay. Okay, the second differential?
It could be a glomerulonephritis as part of a mixed connective tissue disorder.
Okay. Okay.
It could be essential hypertension.
Yeah, it could be just a simple essential hypertension.
Yeah, it could be essential.
Okay. With just a simple Raynaud disease, most probably because of the smoking and because of the, primary Raynaud disease, not or Raynaud phenomenon, not a secondary Raynaud disease because of the underlying scleroderma. Okay.
Okay.
Okay, you did well. I don't think anything left for me to ask you about this case. Okay, what's your approach? What's your approach for hypertension? From the beginning, I noticed that you are not, you are keep shifting and jumping from one system to another system. You asked me about the past medical history, then you came back again to the history back. So I want to know, what's your approach for hypertension? If the patient,
well, to be honest, I just first, because I know it could be cardiovascular or it could be renal and connective tissue disorder.
Okay, so what's your sequence of your question? What are you going to say if you're facing the exam as a case like this, hypertension? Instead of jumping from one system to another aspect of the history, go back to the examination, then ask the patient again, do you have an approach?
Yeah, then I thought, I asked wait for metabolic causes. I asked symptom of a cardiovascular system to see if it's the cause would be related to this. But then when I couldn't catch anything, I just thought that maybe past medical history would help me to go through that. Then I went for connective tissue disease after you showed me. But renal or connective tissue, cardiovascular systems such as coarctation of the aorta, and metabolic causes for hypertension, which was not valid in this case at all.
Okay, thank you. Just try to be more organized in the exam. No need to panic, no need to jump from one part of the history into another. Don't let the examiner go step by step. I know that most of us, when they couldn't figure out what's happening here, they will just ask the patient about the past medical history. And in this case, past medical history was not really helpful. Then you went back again to the connective tissue question. So I would rather go step by step, try to be relaxed on the exam, try to be focusing on the sequence of the question that I have already prepared, instead of jumping from one system into another, And I remember at one point while you was explaining the condition for me, you asked me about alcohol. I'm right. Hello.
Sorry.
I remember while you was explaining for me the condition, the systemic sclerosis, you asked me about alcohol.
Yes, at the end of the because that is the part of the history from this, but I didn't find it very important to miss at the beginning until I explained for the patient. But at the end, when I've got time, I thought maybe I have to cover that as well.
Well, I don't think the examiner will deduct any mark from you, but just to leave a good impression for the examiner, so he will not be harsh on your final assessment. He will not put any, I don't know, but how can I explain it? But just always try to go in organized sequence rather than jumping from one system to another system. It will leave a good mark on the examiner. The examiner will think that you are knowing what you are doing, even if you don't know what you are doing, even if you didn't catch the diagnosis yet. But the examiner will think in a good way about you. Okay, no need to panic. Just try to relax. At the end, you will be able to figure out what is the diagnosis. And most of the people usually in station 5, I'm not talking about station 2 or station 4, station 5, usually most of the people got the right diagnosis. The issue is either in the differential, the issue is either in the concern. This is where most of the people fail and lose mark. But to get the right diagnosis, I don't think it will be an issue for the people at the exam. Either identifying the physical finding, the concern, or maybe sometimes the differential. Those where most of the people fail. They don't fail to get the right diagnosis. Okay.
Okay.
Okay. Good job, Dr. Shaza.
Thank you.
Okay. Let me start from the beginning. If people are still interested to listen. Okay. So Mr. Justin presented with high blood pressure. So just to explain quickly for all of you, my approach for the exam for hypertension was I was following this picture. Just let me share it with you. It's a simple algorithm. It will always keep me in, it will always show me if I'm going in the right direction or not. It is very simple algorithm. Let me share it with you. Okay, can you see this?
Yes.
Okay, hello. Can you see
Yes.
this? Okay, so the first question I usually ask the patient if he had a high blood pressure, I will ask him about the weight gain. If there is a weight gain, I will think immediately about acromegaly or Cushing syndrome or hypothyroidism or obstructive sleep apnea. Every one of them has his own screening question. Acromegaly, as you know, there are many screening questions, but we usually ask the patient if there is a recent increase in the size of the hand or the feet, the hands or feet. Cushing syndrome, you will ask the patient about the weight gain. Is it all over his body or is only around his tummy? You will ask the patient. In addition, this patient has a high blood pressure. He may have a high blood sugar. He may have an easy bruising. He may have. I will ask the patient about the symptoms of Cushing syndrome. Hypothyroidism, you will ask about the weight, the constipation. You will ask about the fatigability. Sometimes usually the weather preference. Okay, obstructive sleep apnea, we have already discussed it on the last session. Usually we ask the patient about the sleep issue, if he had any excessive snoring, if he is awake at the night with some difficulty of breathing, if he had a morning headache, and if he had any difficulty in concentration or excessive daytime sleepiness. If the patient told you no, I don't have a weight gain, then you have to ask about headache. The only disease that is usually present with headache, and it is not, or headache is the main part of the disease, because all the patients who have hypertension, they may present with a headache. The headache most probably because of hypertension. But in pheochromocytoma, the headache is part of the disease process itself. Usually remember pheochromocytoma, you have a triad of palpitation, headache, in addition to episodic headache, palpitation, in addition to excessive sweating, plus or minus tremor. Those are the screening questions for pheochromocytoma. If the patient told you no, I don't have a headache, then and you have already excluded the pheochromocytoma, you have to ask about the renal symptoms. Why the renal symptoms? We will ask the patient about the amount of the urine, the frequency of the urine, the calorie change. This is very important question because of the hematuria, any blood or any calorie change into the urine. And then we're going to ask the patient about the froth in the urine or bubbles in the urine. This is to diagnose glomerulonephritis. In the exam, usually glomerulonephritis, if your case was glomerulonephritis, it will be one of the four types. Either post-strep or post-infectious glomerulonephritis, like post-streptococcal glomerulonephritis or IgA nephropathy. It could be lupus nephritis, or it could be rapidly progressive glomerulonephritis in a patient with a beginner granulomatosis or Goodbacher syndrome. This is usually the short list of differential for the patient with glomerulonephritis in the exam. Then it could be polycystic kidney disease. Ask the patient about the family history. And it could be renal artery stenosis. Renal artery stenosis, there is a two-way to diagnose renal artery stenosis at the exam from the history. The first one, if the patient develops flush pulmonary edema. The second one, if the patient's symptoms start, if the patient high blood pressure start worse after he start using the ACE inhibitor. Okay, this is the second way to diagnose the renal artery stenosis from the history. It's one of the conditions that is very difficult to diagnose it from the history. Okay, let's say that the patient told you, no, I don't have any urinary symptoms, no change in the amount, no change in the frequency, no change in the color, there is no froth in the urine, no blood in the urine, no puffiness of the eye. This is most probably will not be a renal condition. I have to ask about hypokalemia symptoms. Patient with hyperaldosteronism, remember hyperaldosteronism or adrenal hyperplasia, this is the most common secondary cause of hypertension. And sometimes in the exam, sometimes hypokalemia associated with hyperaldosteronism may be asymptomatic. But what are the symptoms of hypokalemia that I should be aware of and I should ask the patient from? I will ask the patient about the muscle cramp, the fatigue, the palpitation, and constipation. Those are some screening questions for the hypokalemia. But sometime in the exam, the patient will be asymptomatic, and you will diagnose hyperaldosteronism from the investigation that will be given to you before you go into the station. Sometimes they will give you a referral letter from the GB, show the potassium is high. If the potassium is more than 5.5, more than 5.4, 5.3, think about, sorry, if the potassium is low, sorry, if the potassium is more than 3.5, 3.4, 3.2, 3.1, think about hyperaldosteronism. If the patient told you, no, I don't have those symptoms, and there was no any hint or clue that this patient has hypokalemia, I have to ask the patient about the joint pain, skin rash, and skin tightness. Why joint pain? Joint pain, skin rash, and skin tightness, just to exclude lupus nephritis and just to exclude the systemic sclerosis, similar to our case. So if I was following this algorithm and I couldn't figure out what is the reason of hypertension, and if I arrive at the point of the asking those questions, the point where I should ask about the skin tightness, and he told me yes, I will think about the maybe systemic sclerosis. The issue in our scenario, the patient did not complain from skin tightness. The patient complained from Raynaud phenomena. The patient complained from the discoloration of the hand. So it is not necessary that the patient will tell you I have a skin tightness. He may have another symptoms of the SLE, like for example, a lady with recurrent abortion. Okay, the patient may have maybe some sort of any hair loss, for example. SLE sometimes can be associated with hair loss with hypertension. Okay, in addition to the joint pain. So remember that those questions will help you or will guide you towards the diagnosis, but sometime in the exam, you may not find the patient presented with the typical symptoms of the condition. He may not tell you that I have a skin tightness, okay? He may not tell you I have a skin rash on sun exposure for the SLE. He may tell you that I have a mouth sore, for example. I may have a hair loss for the SLE, for example. If the patient told you, no, one of the rare conditions, it's unlikely to appear in the exam, rare condition that can cause hypertension is the primary hyperparathyroidism. Ask the patient about the symptoms of hypercalcemia, like the constipation, the frequent and excessive thirst, frequent and excessive urination, the polyuria, the polydipsia, sometimes the mood change, sometimes the headache. Those are the symptoms of hypercalcemia. And it is unlikely in the exam your case to be primary hyperparathyroidism, but I just involve it in this algorithm so you can maybe you can use it if you want. Then we will go to the past medical history. Any chronic condition I should be aware of. I think by this time the patient will tell, if all the previous question came negative, by this time the patient will tell you something from the history. If he told you no, there is nothing, I don't have any chronic condition, you have to ask about the drug history. In the drug history, the recent use of ACE inhibitor, this will give you a strong clue that this patient had renal artery stenosis. If the patient told you I have a systemic corticosteroid, think about corticosteroid-induced hypertension, and this is a very common case in Egypt. One of the very common cases in Egypt, that steroid complication, patient using steroid for systemic condition, and now he is presenting with a side effect of the steroid, high blood pressure, high blood sugar, back pain because of the osteoporosis, sometimes dizziness because of the gastric ulcer and the bleeding and melena. So remember, corticosteroid is very important question in the patient who have high blood pressure. Then the non-steroid anti-inflammatory drug, it's debatable whether the non-steroid can increase the high blood pressure. And if the patient was a female, you have to ask about the oral contraceptive. Oral contraceptive can also increase the high blood pressure. And the last question is the recreational drug, amphetamine and cocaine. Both of them can increase the high blood pressure. It can cause high blood pressure. Then you have to ask about the family history. In the family history, one of the important systems that we want the patient to tell us about, if there is a family history of kidney disease. Family history of kidney disease usually will give you a clue toward adult polycystic kidney disease, or sometimes it can give you a clue toward primary hyperparathyroidism, although it is unlikely in the exam. If the patient told you, for example, I have a renal stone, recurrent renal stone, this is most probably that this patient has primary hyperparathyroidism as a part of multiple endocrine neoplasia, but it's unlikely in the exam. Just focus on the family history of kidney disease. Then in the social history, ask about the caffeine and alcohol. Both of them can increase the blood pressure. If you couldn't figure out the reason of the high blood pressure from the history, then you have to focus on the examination, okay? Either from the examination, you will find a clear spot sign directing you toward the final diagnosis. For example, a patient with skin tightness, he may not tell you that I have skin tightness. He may not tell you I have sclerodactyly, but when you examine him, you will notice that this patient has sclerodactyly or skin tightness. Patient with a hair loss, also, it will give you a clue that this patient may have an SLE with lupus nephritis. The kidney is involved, and this is why this patient has a high blood pressure. Patient with skin rash, also, it could give you a clue toward the SLE. Okay, so sometime in the history you may not be able to figure out the reason of the high blood pressure, but from the examination you can know what is the reason behind the high blood pressure. For example, patient with severe excessive rash or scarring rash following the pemphigus vulgaris, for example, you will notice some bully and some ruptured bully, and patient taking most probably this patient is taking steroid, and this is why he had the high blood pressure. Patient with acromegaly, once you step inside the exam room, you will notice this patient has an acromegaly. You know before you go in that this patient has a high blood pressure. But once you go inside the exam room, you will notice this patient has a clear feature of acromegaly. So the diagnosis here is clear, and the patient has an acromegaly, and this is the reason behind the high blood pressure. Okay. So you can use this algorithm. It will guide you toward reaching the diagnosis of the hypertension. But remember, sometimes you will not be able to diagnose the secondary cause of hypertension just from the history. Sometimes you have to focus on the examination. Any question in this algorithm or in this symbol diagram? Hello? Any question?
Is this diagram how we will finish this in 5 minutes?
Sorry, doctor, I can't, your voice is not clear. Hello? Sorry, Dr. Mohit.
How can I finish all of this in 5 minutes?
I don't know. I think with the practice. I think with the practice you will be able
how I
to.
can finish.
I think with the practice. And by the way, there are some questions. For example, in the drug history, you are not going to ask the patient specifically about the steroid. Are you taking steroid? Are you taking non-steroid anti-inflammatory drugs? You are not going to ask the patient in that way. You're going to tell him, just show me your list of chronic medication, and that's it. Okay? Are you taking any over-the-counter medication? That's it. Do you smoke? Do you drink alcohol? That's it. Okay? Do you have a weight gain? No, I don't have a weight gain. Then you will go to the next step. Do you have a palpitation? Do you have? So the question, I think it, for me, honestly, while I was preparing for the PACES, it never was an issue. The issue for me, when the secondary cause of hypertension is usually I'm going to get it from the examination. That was really the annoying part for me. When I couldn't figure out the secondary cause of hypertension just from the history. When you left just with the examination to detect the secondary cause of hypertension, that was really the annoying part of the hypertension cases in station 5. Okay, but I didn't find any issue asking this question. I think with the practice, you will never find it an E. I don't know. This was my algorithm. This was my approach for the patient with hypertension and high blood pressure in station 5. But if you have something more easier, if you have something that you think more convenient for you, you can always use it. The target in the exam is to reach to the diagnose and get the full mark. It is not about the approach or the preferred approach. The preferred approach is always the approach that you like and you think that it is very easy for you to recall it in the exam and under the stressful condition.
Can you show us the hands again and tell us what is the positive finding in the hand in this patient?
Sorry, I can't hear your voice, Dr. Mahir.
Show us the photo of the hand again and tell us the positive finding in this hand.
Okay. I'm going to share with you that picture in addition to other picture. But before that, let's discuss systemic sclerosis just quickly. What are the symptoms of systemic? The screening question for systemic sclerosis. I'm going to mention them just quickly for the people who are listening to us. I'm going to ask the patient from the hand. Usually in the hand there is a skin discoloration. Skin discoloration usually suggests when you expose your hand exposed to the cold. This is one of the symptoms that suggests this patient has a Raynaud phenomena. The skin tightness, the shining skin, sometimes the pain when he exposes his hand to the cold is also suggestive of Raynaud phenomena. Then you have to ask the patient if there is any problem combing hair or climbing the stairs. Proximal myopathy could be a symptom of mixed connective tissue disease or systemic sclerosis. Then I am going to ask the patient about the headache and the blurring of vision because it could be symptoms indicate that this patient has hypertension. Then I'm going to ask the patient about the heart pain, the dysphagia, the nausea, the vomiting, the abdominal pain, and the bloating. All those the gastrointestinal symptoms related to the systemic sclerosis. Remember also to ask about the shortness of breath because it could indicate shortness of breath with a minimal exercise or fatigue with the minimal exertion. This usually suggests that this patient may have underlying interstitial lung disease or pulmonary hypertension. Okay, so those are usually the screening question for systemic sclerosis. Systemic sclerosis in the hand, the clinical finding that we can, or let's talk about the examination about the systemic sclerosis. I'm going to share with you just a quick picture. Can you see this? Hello?
Yeah.
Hello? Can you see this picture?
Yes.
Okay, this is just quickly the examination for the patient of systemic sclerosis. How we will examine a patient with systemic sclerosis. Always start with the vital sign. The patient may have a high blood pressure. Then you can examine the hand. You will notice the skin thickening and the skin shining. You may notice the skin thickening and the skin shining. And then you may notice that hyper and hypopigmentation. Hyper and hypopigmentation, it's a rare finding. It will give you an appearance of salt and pepper appearance. Sometimes we may notice that this patient has, sorry, I'm going to share it again. Sometimes we may notice this patient has a Raynaud change related to Raynaud phenomena. The color change. Usually, when the patient exposed to the cold and he had a Raynaud phenomena, his hand color is going to change into the white, then into blue, then into red. The white discoloration usually because the patient has a vasospasm. Then when it turns to blue, this indicates that the patient had an ischemia. When it turns to the red, this indicates that reperfusion, the normal reperfusion has been restored, and this is the stage where the patient develops the pain. When it is white and blue, the patient usually complains from some tightness, and when the hyperemia occurs, or the reperfusion of the fingers occur, the patient will develop the pain. Sometimes the patient may have a pitting, sometimes erosion, scar, ulceration, and even gangrene or auto-amputation of the fingers. Swelling of the hand and the finger. This is, by the way, the earliest signs in the patient who had systemic sclerosis. Then the patient may have calcinosis cutis, deposition of some calcium deposit in the hands. The patient may have telangiectasia, and the patient may have some flexion contraction. You will notice that his fingers are flexed, and the heart rate, it could be fast or low heart rate. Then when we go into the arm, we will notice that this patient may have a proximal myopathy, either because of systemic sclerosis or sometimes combined mixed connective tissue disease. When we go into the face, we will notice the thickening of the skin face, which will lead into the difficulty in opening the patient mouth, and sometimes we may notice the telangiectasia. The patient with systemic sclerosis, they may also develop pulmonary hypertension. Pulmonary hypertension, we will notice that this patient has a right ventricular heave. The patient has a loud pulmonary component of second heart sound. Sometimes the patient develop a heart failure. You will notice that this patient has a third heart sound and even crackles. And sometimes the patient develop pericardial effusion. So you will notice they may have a distant heart sound. Okay. When we examine the basis of the lung, we will notice that this patient has a coarse crackle, which suggests if he had interstitial lung disease. And when we examine the abdomen, if the patient has bacterial overgrowth, or if the patient has a pseudo-obstruction, pseudo-intestinal obstruction, he may have abdominal distension. Okay. In the lower limb, the patient may have a leg edema if he had a heart failure. Okay.
Dr. Ala, this flexion contraction, this means the sclerodactyly of the fingers?
Sclerodactyly
This is the same meaning.
the skin thickening and stretching. This is the sclerodactyly. The flexion contraction, because of the thickening, you will notice that this patient has sometimes contraction, flexion contraction. You will notice that the fingers are flexed in flex posture.
I asked one patient in exam, do you have any stiffness? She said, yes, I have a stiffness. And this was the problem with me. Patient said, I have a stiffness. Because this flexion contraction, she cannot move her hands.
Yeah. If the patient has this flexion contraction because of the thickening of the skin, and usually because there is underlying fibrosis of the connective tissue of the hand, usually the patient may complain from stiffness, difficulty in moving the hand, difficulty in moving the fingers. Okay. So this is the examination for the patient with systemic sclerosis. Just remember in the symptoms, I'm sorry because I didn't mention it in an organized way. Usually the symptoms in the hand, usually the patient in the hand will have the skin thickening, skin tightness, and sometimes the Raynaud phenomena. If you go into the arm, he may have the weakness. You will ask him if he had any difficulty in combing the hair or climbing the stairs. In the head, he may have, because of hypertension, he may have high blood pressure, and sometimes visual disturbance, and sometimes even seizure if the patient has renal cell crisis. In the lung, the patient has a shortness of breath, usually because of the interstitial lung disease or because of pulmonary hypertension. In the mouth, the patient and the gastrointestinal tract, the patient may have a heartburn, the patient may have a dysphagia. This is usually because of the esophageal dysmotility and because of the GERD. Patient with systemic sclerosis develop GERD and esophageal dysmotility. If the stomach was involved, the patient may have gastroparesis. The patient would have a nausea and vomiting, and sometimes a weight loss. This is because of the gastroparesis. And sometimes patient develop something we call it the watermelon stomach. Watermelon stomach. It's usually the main cause of the. It's one of the causes of the iron deficiency anemia in the patient with systemic sclerosis. They will have something we call it gastric antral vascular ectasia, or watermelon stomach. There is some bleeding can happen at the site of the stomach, although it is rare, but it can cause iron deficiency anemia. in a patient with systemic sclerosis. So in the esophagus, usually the patient will have GERD or esophageal dysmotility that will be reflected in the symptoms of heartburn and symptoms of difficulty of swallowing. Gastroparesis, usually the patient presents with nausea and vomiting and sometimes bloating and sometimes weight loss. In addition to iron deficiency anemia, if there is gastric antral vascular ectasia. If the intestine has been involved, the patient will develop bacterial overgrowth. Bacterial overgrowth, usually the patient presents with a diarrhea or with anemia or with a bloating. Or sometimes, if the intestine has been involved, the patient will develop pseudo-obstruction. Pseudo-obstruction, the patient will present also a nausea, vomiting, abdominal pain in addition to the distension. Okay, so this is the history, this is the examination, and how we diagnose systemic sclerosis. Diagnosis of systemic sclerosis usually it's a clinical diagnosis. It is not a diagnosis of the. It is not a diagnosis of the investigation. It is not a diagnosis of the of imaging. Usually, systemic sclerosis diagnosed clinically. Plus or minus, you may need to do the antibodies. This is the only test that you may need in a patient with systemic sclerosis. I'm going to share with you just quickly one of the clinical criteria to diagnose systemic sclerosis. It is from the American College of Rheumatology and European League Against the Rheumatism. No need to recall this criteria. No need to remember this criteria. It is not important for us at the level of the PACES, but just to emphasize one point that systemic sclerosis is diagnosed clinically. Okay. You only need those antibody, anti-centromere antibody, anti-topoisomerase 1 antibody, which we call it anti-scleroderma 70 antibody, or anti-RNA polymerase 3 antibody. Okay? This is the only test that you need, but there is a scoring system. No need to remember it. No need to spend your time on it. But just remember that the diagnosis of systemic sclerosis, usually it's a clinical diagnosis. We need some clinical criteria. Based on those clinical criteria, we can diagnose systemic sclerosis. Sometimes we may need the antibody, anti-centromere antibody, anti-topoisomerase 1 antibody, and anti-RNA polymerase 3 antibody. Okay. Remember in the exam, one of the important organs that can be involved, it's a kidney. Usually the patient with systemic sclerosis, they may have a kidney involvement, asymptomatic kidney involvement, asymptomatic chronic change happening within the kidney, or sometimes they may develop scleroderma renal crisis. Okay, the renal crisis. If the patient has asymptomatic involvement of the kidney, they may present with isolated hypertension, they may present with isolated proteinuria, they may present with chronic kidney disease. I mean, decrease in the glomerular filtration rate. Okay, this is like our case today. The patient just has isolated hypertension. If we do a urine dipstick, we can find this patient has a proteinuria, or we may find that the glomerular filtration rate is reduced. Patient with renal crisis, scleroderma renal crisis, usually they have accelerated hypertension, very high blood pressure. This very high blood pressure can cause blurring of vision in addition to headache, in addition sometimes to seizure, and usually it can affect the fundus or the retina of the patient, some retinal change can happen. This is why we need fundoscopy or ophthalmoscopic examination of the fundus. If the patient has accelerated hypertension, we may notice that this patient has a flame, a hemorrhage, dots and blots hemorrhage in addition to papilloedema if the patient has accelerated hypertension. The second symptoms of the renal crisis, in addition to accelerated hypertension, the patient may present with acute kidney injury. Acute kidney injury, the patient will present with anuria and oliguria and very high creatinine, more than 50% increase in the baseline creatinine. In addition to that, the patient may present with anemia and thrombocytopenia, hemolytic anemia and thrombocytopenia. All those are symptoms of renal crisis if it happened in the patient with scleroderma. But if there is only the chronic kidney involvement without the severe crisis, the patient present with only isolated proteinuria and hypertension. Okay. The last thing is the management of the systemic sclerosis. Usually, the management of systemic sclerosis depend on the symptoms that the patient has. Okay. Systemic sclerosis, if the patient present with, for example, Raynaud phenomena, we're going to give the patient some advice regarding the lifestyle modification, such as wearing gloves, avoiding the cold, stop the smoking, in addition to usually avoid using the vibrating tools. And we are going to refer, if he finding any difficulty in his work, we're going to refer him to the occupational therapist. In addition to that, we can give the patient calcium channel blocker. This is the first line of management. If the patient did not respond to the calcium channel blocker, we can give him phosphodiesterase inhibitor like the sildenafil and tadalafil. Then we can give the patient IV prostanoid as the last line of management in the patient with Raynaud phenomena. If the patient presents with interstitial lung disease, usually the preferred medication is the cyclophosphamide. If the patient presenting with if the patient is presenting with gastrointestinal symptoms, we will give the patient, all the gastrointestinal symptoms are being treated with proton pump inhibitor or prokinetic agent. And sometimes we can give the patient some antibiotic, rotational antibiotic from time to time. If the patient has pulmonary arterial hypertension, we will give the patient endothelin receptor antagonist, or we can give him phosphodiesterase 5 inhibitor, or we can give him IV prostacyclin. Endothelin receptor antagonist like bosentan, phosphodiesterase inhibitor like sildenafil and tadalafil, IV prostacyclin, it can be used as the last line of management. If the patient presents with the renal symptoms similar to our case today, we are going to give him AC inhibitor. If the AC inhibitor failed, we can give him calcium channel blocker, or we can give him angiotensin receptor blocker. And if all of those fail, we can give the patient doxazosine. Beta blocker, usually they are relatively contraindicated in the patient with renal crisis, scleroderma renal crisis. Usually they are not preferred or relatively contraindicated. Okay. If the patient has severe hypertension, we have to admit the patient and we have to give him intravenous agent for the blood pressure rather than give him just an oral medication. Okay. So this is scleroderma or systemic sclerosis. Remember the differential diagnosis for systemic sclerosis or rheumatoid arthritis or SLE, or your case in the exam was Sjögren syndrome. Remember that your first differential will be always the mixed connective tissue disease. Okay, mixed connective tissue disease. Usually your first differential in all the patients presented with systemic sclerosis or rheumatoid arthritis or systemic sclerosis or Sjögren syndrome. What is the contraindication in renal crisis? The beta blocker. Why beta blocker are it is relatively contraindicated. Why it is relatively contraindicated? Because this patient has a very high vascular resistance. Okay, with the very high blood pressure, if you give them beta blocker, the cardiac output may reduce. And those patients usually they have sometimes those patients with the severe renal crisis, they may develop flush pulmonary edema, or they are just how can I describe it? But I can they have the very high potential to develop pulmonary edema. So we want to avoid the beta blocker as much as we can, because at any point they may develop pulmonary edema, and pulmonary edema, as we know, beta blocker are contraindicated with them. So it is relatively contraindicated. It is not absolutely contraindicated. There are other line of treatment like the AC inhibitor, calcium channel blocker, angiotensin receptor blocker, doxazosine. If it is severe, we admit the patient, we will give him intravenous nitrate rather than give the patient beta blocker. Beta blocker will reduce the cardiac output and this patient has a very high vascular resistance, very high peripheral resistance, this will reduce the cardiac output, and the patient may, at any time, he may develop pulmonary edema. And if he develop pulmonary edema and you give the patient beta blocker, this is a disastrous and fatal for his condition and may make his condition even worse and worse. Okay? If the patient has developed acute renal failure and his condition did not improve and there was an indication for the dialysis, the patient, of course, will go for dialysis. So this systemic sclerosis, I don't know if there is anything left for me to talk about systemic sclerosis. Just I'm going to share with you some picture for systemic sclerosis. So this is the first picture. We can see that this patient has a shiny skin and sometimes there is some form of erythema. This erythema, it could be just following the Raynaud phenomena. I'm not quite sure why it is present in this case, but the shining of the skin and the sclerodactyly is present. The second picture, as we can see, there is a calcium deposition. Okay, the calcium deposition, it is clear in the patient with the systemic sclerosis. Here's one picture. Or the other name of the calcium deposition is calcinosis cutis.
Dr. Ala, I have a question, please.
Yes.
If it is clear from the start that the case is a spot like this scleroderma or acromegaly, should I proceed for the differential of the secondary hypertension, or I go
No. If you got, take it as a rule in the exam, if you got the reason of the secondary hypertension, don't waste your time to exclude the other causes. You stepped inside the exam room and you noted this patient has a Cushing syndrome. Focus on Cushing. Ask about Cushing. Ask about all the complications that can be associated with Cushing. Ask about the acromegaly if you had a case of acromegaly. Ask about all the symptoms of acromegaly: high blood pressure, high blood sugar, the back pain of the osteoporosis, the knee pain for the osteoarthritis, the carpal tunnel syndrome, the obstructive sleep apnea that can be associated with acromegaly. Ask about all the symptoms related to acromegaly and complication of acromegaly. Finish your family history, social history, in addition to the past medical history, but don't waste your time excluding the secondary cause of hypertension while the case is straightforward.
Yes.
Yeah.
But this is unlike the history case. The history, should I figure out all the causes? Yes.
Yeah, in the history, usually in the history in station 2, the proper setup of station 2, usually there is no single diagnosis. There is usually multiple list of differential.
Yes. Okay.
Okay. I don't know if you practice with me the case of station 2, but usually station 2 in the exam, it is different than station 5. In form that station 2, usually there is no single diagnosis. It is it is less likely to have one single diagnosis in station 2.
Okay. Thank you.
Okay.
Okay. Thank you.
Just let's continue quickly with the picture. This is another picture of sclerodactyly and skin shining. Let's show you just one picture of the telangiectasia and microstomia. Okay, this is the telangiectasia at the lips, telangiectasia in the face, and the microstomia, usually also because of the skin tightness and the skin thickening. Sometimes the patient will find it very difficult to open his mouth. Okay, and this is, as we can see, the ulceration that can be associated with the advanced and severe form of Raynaud disease. Patient may develop some form of ulcer, sometimes even gangrene, and sometimes even autoamputation. Let me share with you another picture of systemic sclerosis just quickly. This is again another picture of gangrene, digital gangrene, as a complication of severe Raynaud disease. Okay, there is one final thing I didn't mention it, that there is some kind of bedside test. We do it for the patient with systemic sclerosis. It's called capillary nail fold microscopy. We use a special equipment. We call it microscopy, nail fold microscopy. It is very difficult to use that if you are not familiar with it, and it is unlikely in the exam to do it. Okay, but if the examiner asks you about it, if you find it in extraordinary session or extraordinary exam, just tell the examiner that I would like to examine the nails with the nail fold microscopy, capillary nail fold microscopy. Okay, but this is something usually you are not going to find it in the exam. It is very rare, very rare. If you do the microscopy, the nail fold capillary microscopy, you will notice some change. There is sometimes capillary bleeding, sometimes there is a capillary dilatation, sometimes capillary loss, and some area of devascularization and complete blood loss. But this is something uncommon in the exam, and usually it is not, it's unlikely to get it at the exam site. I'm sorry if I spoke a lot. I'm sorry if I talked a lot about systemic sclerosis, but it's one of the very common topic in the exam, very common case in the exam. Systemic sclerosis can present in multiple ways and many ways, and it's very, very common at the exam. So please be sure to go back, read about it, try to practice the examination of systemic sclerosis with one of your colleagues. So at the exam, if you encountered one of those cases, it will be just a piece of cake case for you. Okay, any question? Any question about systemic sclerosis? Any question, guys? Okay, if there's... Hello?
Dr. Ala, for stiffness of the stiffness in the systemic sclerosis, it is more than 1 hour or less than 1 hour?
Dr. Muhli, don't focus
in the
on
morning,
those things.
early morning.
Don't focus on those simple things, because it is not going to help you at the exam. Believe me. Don't exclude the diagnose or jump into diagnose just because of the duration of the stiffness. It is very difficult just to exclude one of the diagnoses because of the duration of morning stiffness. Stiffness associated with almost all of the autoimmune condition, all of the connective tissue disease associated with joint pain, they have some sort of stiffness. But the stiffness, it is very clear and very characteristic of rheumatoid arthritis. If that means that the other autoimmune condition cannot present with stiffness, no, I can't say so. If that means, if in the exam the patient told me, yes, I have a morning stiffness, should I jump ahead and say this is the patient of rheumatoid arthritis? No, you can't say so. Okay, so don't exclude or jump into your final diagnosis just because of the presence of the stiffness. Okay, stiffness is a very common symptoms associated with most of the autoimmune disease. Unlikely in the exam you are going to diagnose one case, or you are going to diagnose your case just because of the duration of the stiffness. I know with the rheumatoid arthritis, usually the duration of morning stiffness, it's more than an hour, but this is something non-specific. Okay, something non-specific.
Please, I have a question. If it is associated rheumatoid arthritis and the deformity, I think I cannot see the deformity well, because the patient osteoscleroderma will have a deformity in his hand. So I think the deformity of rheumatoid will be not clear. As if it is rheumatoid alone, it's okay. But if rheumatoid was scleroderma, I mean the scleroderma signs will predominate over the rheumatoid, or will also see the rheumatoid signs.
Well, it is very difficult, really. I didn't encounter, honestly, a case in the real life where there is a combination of the both rheumatoid arthritis and systemic sclerosis. But yes, if the both conditions are present in a mixed connective tissue disease, it will be
Yes.
very difficult to diagnose. It will be
Yes.
very difficult to diagnose because of the overlap of the symptoms. Usually, the hand of the patient with systemic sclerosis, they have some sort of flexion contraction. Okay, they will not be a normal hand. In
Yes.
the same time, the patient with rheumatoid arthritis, they may have those characteristic deformity, the swan neck deformity, boutonniere deformity, ulnar deviation. So if the both of them are present in one case, it will be very difficult to diagnose.
Yes.
Okay. So
Yes.
to be in the safe side, you can just tell the examiner this patient may have a mixed connective tissue disease. Mixed connective tissue disease is a quite long topic. I may discuss it later on, maybe on another session. But yes, as you said, if the both conditions are present in one patient, it will be very difficult to diagnose.
Yes. I can put as a differential only.
Sorry?
As a differential, I can put mixed
Yeah, you can
connective.
put them as a differential, yeah. Because when you say to the examiner, this patient may have a mixed connective tissue disease, this means that the patient has an overlap between 4 diseases: systemic sclerosis, rheumatoid arthritis, SLE, dermatomyositis with or without, poliomyositis with or without dermatomyositis. Okay? If the patient has overlap between those 4 conditions, any 2 conditions present together, we call it mixed connective tissue disease. There is a clinical way to diagnose the mixed connective tissue disease in addition to a blood test. The blood test is anti-RMB. This is usually, if it is present, suggest that this patient has a mixed connective tissue disease. And there is a clinical criteria to diagnose mixed connective tissue disease, but I don't think this is the right time to discuss it. It is not necessary for you at the level of the PACES to know that. Okay, but just remember the anti-RMB, and remember that if your case in the exam was systemic sclerosis or rheumatoid arthritis or SLE or dermatomyositis, and the examiner asks you from the differential, you can put one of your differential is always mixed connective tissue disease.
Okay.
This is rule number 1. Rule number 2, to diagnose mixed connective tissue disease, we need to do the anti-RMB. Okay? Ignore all the other information about mixed connective tissue disease because it's a very long topic, very complicated topic, and there's a lot of clinical criteria, more than four separate criteria to diagnose the mixed connective tissue disease, and it is not necessary for us at the level of the PACES to know that.
Okay.
Okay?
Okay, thank you.
One final thing, remember that when the investigation for the patient with systemic sclerosis usually will be directed toward the patient complaint. If the patient has a dysphagia, I'm going to tell the examiner, this patient needs an endoscopy. Okay? If the patient, for example, has, let's say, has anemia, and he has the symptoms of melena or iron deficiency anemia, gastric antral vascular ectasia, I'm going to do an endoscopy also. If this patient has a shortness of breath and I'm suspecting this patient may have interstitial lung disease, I'm going to do an X-ray and I'm going to do high resolution CT chest. If I'm suspecting this patient has a pulmonary hypertension, he had a loud B2, he had a right ventricular heave, I'm going to do an echo. If echo was not diagnostic, I'm going to do right heart catheterization and so on. Okay? For kidney disease, for the kidney involvement, remember that you always have to do the renal function test. You have to do the urea, you have to do the creatinine, you have to do the electrolyte, you have to do the urine protein creatinine ratio. This is for all the patients who present with renal involvement or hypertension in addition to systemic sclerosis. Okay, remember that the investigation will be directed toward the patient presenting complaint. But systemic sclerosis per se, only we need the clinical examination finding in addition to the antibody, anti-centromere antibody, topoisomerase 3 antibody, and anti-ribosome 1 antibody, or anti-scleroderma 70 antibody. Okay, those are the antibody that are important for diagnosing the patient with. You can mention to the examiner, I may need anti-nuclear antibody, I need anti-double-stranded DNA antibody, but all that are not important unless you mention the centromere antibody and anti-Scl70 antibody. And the other name is anti-topoisomerase 3 antibody. Okay, any question? Any question? Systemic sclerosis? Any question? The diagnose? Any question?
Yes, doctor, if you ask about the difference regarding the limited scleroderma and the diffuse at the clinical and the investigation level, what should I do?
Usually they diagnose the limited systemic sclerosis. Usually the patient will have only the skin involvement. And in addition to skin involvement, usually sometimes the limited cutaneous systemic sclerosis will be the early stage of the disease. Later on, after years, the patient may present with diffuse systemic sclerosis. But the investigation and the examination are the same. You are going to examine the patient like this patient with systemic sclerosis. Okay? The sclerodactyly usually just distal to the metacarbopharyngeal joint. It is not proximal. It will be just only to the hand and to the fingers. It's not going to be extended to involve the hand and go up to the elbow. Okay? And in addition to that, usually the patient, sometimes they may have just the GERD or pulmonary arterial hypertension. Okay? Pulmonary arterial hypertension and GERD. And one of the form of the limited systemic sclerosis is the CREST syndrome. CREST syndrome, the patient, in addition to the sclerodactyly, in addition to the calcium deposition, the calcinosis cutis, Raynaud phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. Only those five finding or five symptoms of disease will be present. There will be no renal involvement. There will be no heart involvement or lung involvement. Okay, but it's very difficult. It's very complex. The disease, the systemic sclerosis, scleroderma, it's a spectrum of disease. Sometimes it starts with the limited and progress into the diffuse form, and sometimes it will not progress into the systemic form. The antibody, anti-centromere antibody, usually it is more common with the patient with the limited cutaneous systemic sclerosis, while the patient who has diffuse systemic sclerosis or diffuse scleroderma, anti-Scl70, anti-scleroderma 70 antibody, or the other name anti-topoisomerase 1 antibody, those are very characteristic and very common to be found in the patient with systemic sclerosis, a diffuse systemic sclerosis. It is very difficult in the exam to get only the limited form, but it's fine. If you find that only the hand are involved, no other organ are involved, you can tell the examiner simply this is a limited cutaneous systemic sclerosis.
Dr. Ala?
Yes?
Is the case of morphia has come any time? Localized
Localized systemic sclerosis, I am not quite sure. But systemic sclerosis, per se, the diffuse systemic sclerosis, it is very, very common, and especially in the overseas centers.
Okay, thank you.
Sclerosis. And sometimes you may even get it in station 1. You will get a patient with interstitial lung disease, lung fibrosis, because he has underlying systemic sclerosis. You may get it in station 1 rather than station 5. This is why when you start your examination in station 1, always after you examine the hand, if your case in the exam, during your exam in station 1, while you are doing the respiratory examination, after you examine the hand, just pinch the skin. Okay, try to pinch the skin and look if there is a skin tightness or skin shining. Okay, this will give you a clue before you put your stethoscope, or before you start even the inspection and start the percussion and the other aspect of the respiratory examination. This will give you a strong clue that your patient is a systemic sclerosis patient. Okay, so in station 1, when you start your respiratory examination, just pinch the skin of the hand. I used to do that just to be sure that my case is not a systemic sclerosis case.
Dr. In Ajman, does it such type of case have you seen, or is there any information about it?
Sorry?
In Ajman, this such case, have you any information about?
No, I don't remember that there is a systemic sclerosis case in Iman, but don't depend on that. Don't depend on that. Just prepare.
Okay.
Yeah, just prepare as you are going to the exam blindly. You don't know what you are going to get there. Read all the cases. Try to practice as especially the common cases. There are 5 or 6 topics in rheumatology, 5 or 6 topics in endocrine. You have to know them by heart, like rheumatoid arthritis, systemic sclerosis, SLE, Sjögren's syndrome. You have to know them by heart. Then in the endocrine, thyroid heart disease, there is no PACES exam without thyroid disease. No way.
Okay.
No way for a center to have a PACES exam without thyroid disease. You may not get it, but your colleague will definitely get it. Okay, so you can go into the PACES exam without preparing well for the thyroid disease. Thyroid disease, Cushing disease and Cushing syndrome, in addition to acromegaly, and those are the very, very common in the exam. You have to know them by heart. So there is like 10 topics. You have to know them by heart, not just by you can't just revise them quickly. You have to know them by heart.
Okay, inshallah.
Okay, thank you everyone. I hope I was able to give you something useful, or I teach you 1 or 2 new things. But systemic sclerosis is very common, very common, either in station 1 as a respiratory case with lung fibrosis, or at station 5. Sometimes the patient may present with dysphagia, sometimes diarrhea, sometimes with hypertension, and sometimes with pulmonary hypertension and shortness of breath. So there are many ways to bring one single systemic sclerosis case with multiple symptoms over different day and different center. Okay, thank you everyone. If there is no question, I think we will stop here. I hope we will be able to meet soon, or we will have another session soon, inshallah. And good luck for all the people who are going to take the exam during 2020 or during the first date of 2021. Thank you, everyone. Thank you, all of you.